Our next speaker will be Dr. Tibor Becske. He is going to speak to us about the PUFS trial, long-term clinical and angiographic outcomes following PED treatment of complex ICA aneurysms and the 5-year results of the PUFS trial. Dr. Becke's work he's the recipient of the overall neurosurgery top paper of the year. Congratulations.
Thank you very much. I would like to make it clear that the honor is not mine. I'm representing a large group of investigators, and I will show them on the screen. In particular, I would like to thank my mentor, an innovator, an educator, and a friend, Peter Kim Nelson, who's the senior mind behind this effort. This is my disclosure. So the pipeline device was developed to provide a higher metal coverage across aneurysm necks in wide neck aneurysms while maintaining patency of adjacent branch vessels. And the goal in mind was to provide standalone treatment for aneurysms, that is, without having to go inside the sac and coil the aneurysm. This is an example showing the flow disruption effect of the devices. You can see on the top right side the devices were deployed, and you can see in sequential angiographic pictures how the aneurysm is not circulating. The contrast is trapped in the aneurysm. That leads to thrombosis, and ultimately then after the thrombosis, as shown here on Dr. Kalmus' slide from a rabbit aorta from Mayo Clinic, the aneurysm heals and the stent gets incorporated in the vessel wall. This is a scanning electron microscopic picture of a branch vessel seen on the rabbit aorta here again, and you can see the entire surface is covered with endothelial cells, including the individual struts of the device, yet the runoff keeps the branch vessel, which is a lumbar artery in this case, open. So that was the concept. And the PUFS trial was conceived as a multi-center, single-arm prospective trial encompassing 10 centers on 2 continents. We enrolled 108 patients with 110 aneurysms, and we had 106 aneurysms in the effectiveness arm. Coiling was not allowed in the trial. These are the sizes. The mean size of the aneurysms was 18.2 millimeters, and the mean neck size was 8.8. So these are very highly complicated aneurysms. This is just the distribution. About close to 80% were large, 20% were giant, and there was one small aneurysm that was excluded from effectiveness but was kept in the safety evaluation. Historic data was used for control, for comparison, and we defined the primary effectiveness endpoint at 180 days on an angiographic study that had to show that the aneurysm was completely occluded using pipeline device or devices alone without adjunct coiling, and there couldn't have been a significant neurologic complication, and the parent vessel had to be patent with no significant stenosis. This was all judged by an independent core laboratory and a safety committee. The primary safety endpoint was defined as an incidence of major ipsilateral stroke or neurologic death at, again, 180 days. These are, I would just like to point to the co-investigators, and again, thank all of them at Mayo Clinic, at Barrow, at Rush University, St. Louis, Central DuPage Hospital, University of Buffalo, SUNY Stony Brook, and NYU Medical Center for the excellent and tedious work that they put in. And similarly, thank you to István Sikora and his team, and Saruhan Çekirge and his team in Budapest and Ankara. These were the demographics, nothing unusual except that the aneurysms turn out to be mostly in females. The most of the aneurysms in this particular population were 90% of them were in females. 8 of these aneurysms had had prior rupture, and 6 of them had had prior coil embolization. Anatomic distribution, you can see about 44% of the cases were outside of the dural sac. cavernous segment or petrous. The rest were in the proximal supraclinoid carotid artery, proximal to the posterior communicating artery, as per the FDA's wishes. The primary effectiveness analysis showed that 74% of the aneurysms were completely occluded and met the primary effectiveness endpoint, which was statistically significant. And here's just a couple of pictures to show you the types of aneurysms we were treating and the types of outcomes we were seeing. This is a large, very complex ophthalmic segment aneurysm. This is a 6-month follow-up angiogram, and you can see in the right panel the devices in place. This is a symptomatic, very large, complex cavernous aneurysm, and you can see again the 6-month follow-up on the right panel. And here I have an MRI as well, and you can see with the red arrows, you can see the aneurysm before treatment, and you can see at 1 year and 5 years the aneurysm is completely gone from the MRI. The primary safety analysis demonstrated 6 out of 107 safety events for 5.6%, which again met the preset criteria. These were the events. We had 2 apparent artery thromboses with stroke. There was 1 stenosis with stroke. There was 2 large hemorrhages, clinically significant hemorrhages, but not subarachnoid hemorrhages, and 1 possible neurologic death within 180 days. At 5 years, to jump to the end of the 5-year trial, we had 103 surviving patients, 81 of which had completed clinical follow-up, and 61 patients with 63 aneurysms completed 5-year angiographic follow-up. Here in this slide, you can see a summary of angiographic aneurysm occlusion over time. You can see on the 180 days, we have 74% complete occlusion, and it's gradually increasing to a 95% occlusion by 5 years. The residual necks and the residual aneurysms actually are shown here. So we had 15 remnants found at 6 months, of which 6 were retreated and 9 had no retreatment. In all, 11 of the 15 had progressed to complete occlusion, with 3 remnants, and 1 patient was lost to follow-up. We observed 6 carotid occlusions in the trial over 5 years. The first 3 were between 0 and 6 months, 2 were 6 to 12 months, and there was 1 between 1 and 3 years, only 1 of which was neurologically symptomatic with a stroke. That patient just so happens that she stopped taking her aspirin and Plavix after a couple of months. In terms of delayed safety events after the 6-month primary effectiveness evaluation, we had no ipsilateral strokes, intraparenchymal hemorrhages, or neurologic deaths after 6 months of follow-up. We had 1 non-neurologic death, 3 device-related significant or serious adverse events, all between 6 months and 3 years. 2 of them were amaurosis fugax, and there was 1 silent parent vessel occlusion, neurologically silent, presenting only with headaches. So in summary, the pipeline device has proven to be a valuable new way of treating and flow diversion in a larger sense, treating these large and giant wide neck aneurysms in the anterior circulation. The 5-year angiographic occlusion rate was 95%. Overall angiographic occlusion rate was close to 90%. We had observed no aneurysm recalizations. There was 1 rupture in the trial which happened in a cavernous aneurysm, resulting in carotid cavernous fistula. Aneurysmal subarachnoid rate was 0, and the major ipsilateral stroke and neurologic death rate was 5.6%. As I mentioned, parent vessel occlusions occurred in 5.6%, and high-grade in-stent stenoses, other than the parent vessel occlusions, in 2.8%. That's it. Thank you very much.